Very nice. Good morning, good afternoon, or good evening, wherever you are, dear colleagues from all over the world. And welcome to this fourth session on a deep dive on big catch-up monitoring. This time we are going to focus on Ethiopia's work. This session is organized by the World Health Organization, UNICEF, Gavi, with the support of TechNet. You can listen to this session in English and in French. To do so, please click the globe icon at the bottom of your screen and select the language in which you'd like to listen to this session. Now let me say that in French for our francophone audience. Vous pouvez écouter cette session en français. Pour ce faire, cliquez sur l'icône en forme de globe et sélectionnez la langue dans laquelle vous souhaitez écouter cette session. C'est en français, en anglais ou en portugais. I'm afraid I cannot say that in Portuguese, so I hope you understand at least French or English to select the language you wish. We'd be happy to know who's with us today, so don't hesitate to introduce yourselves in the chat as usual and tell us from which country you are and for which organization you work. That would be very nice. If you have any question during this presentation, you can use the Q&A box. The Q&A box is available at the bottom of your Zoom window. The questions will be answered during the Q&A session, so don't hesitate to ask questions at any point. If you have any technical issue, you can mention that in the chat and I'll do my best to help you fixing the potential issues you may encounter. Finally, this session is recorded as per usual and we'll share with you probably next week the links to the video as well as the slides by email. It will be posted on the TechNet website. I hope you'll enjoy this session and I will give the floor to Sarah. Sarah, the floor is yours.
All right, great. Thank you very much, Alex. I like how you say my name, Sarah. Sarah. All right. Hi, everybody. Thank you very much for joining us for our last session on these deep dives for Big Catch-up. And for this session, we are featuring last but not least, Ethiopia, which, if you recall, was one of the countries that had one of the highest numbers of zero-dose children based on the WUNIC estimates from 2022, looking at the cohorts of children from 2019 to 2022. And since that time, Ethiopia has embarked on a journey of developing a recovery plan where they've implemented several activities to identify, reach, and vaccinate these children. And so today we're going to bring them over to actually talk about how they've done this over the last few months. But before that, we shall hear from Ariel and Ibrahim Dadari on the global overview of zero-dose situation, as well as the monitoring and evaluation guidance. So over to you, Ariel.
Great. Thank you so much, Sarah. And actually, Ibrahim, so over to you, and then I'll come in later. Thank you.
Okay. Thank you, Sarah. Thank you, Ariel, Alex, and colleagues. Good morning, good afternoon. My pleasure to be here to go into the Ethiopian deep dive on the big catch-up. So we're going to look at what's the current status of zero-dose children globally, as well as the monitoring guidance piece, and also learn from what Ethiopia is doing. Next slide, please. So globally, we have the Immunization Agenda 2030, which is the global document that guides immunization programming in this current decade between now 2021 and 2030. And the target was basically using 2019 as our denominator to reduce the numbers of zero dose by 25% by 2025 and 50% by 2030. If you look at this slide, you could see in 2019, basically we had the Africa region had around 6.2 million zero-dose children, which is the blue bars, and then the gray bars are the additional under-vaccinated. So you're looking at a total of 8.6 million in 2019. During the pandemic, we had this significant backsliding. Basically, there's been substantial increase in the numbers of zero-dose children globally, not only in the African region. but also a corresponding increase in the numbers of under-vaccinated as well. And this is what the big catch-up was trying to assist or help countries to be able to catch up on those students that missed their vaccines primary series, particularly during the pandemic years of 2019 to 2021, 2022, and then put us back on track towards catching up, restoring and strengthening the system such that we'll be able to meet the targets of the immunization agenda 2030. The peak of the backsliding you could see from the slide has been around 2021, 2022, but then we've been seeing a decline towards normality, but still we're off track. So you could look at the two bars at the bottom, you could see still relative to 2019, we have more numbers of zero-dose students, 6.7 million in the African region compared to 2019 where we had 6.2. Actually, we should have been, if we're following the targets of IE 2030, we should have been much lower than 6.2, but we're still off target. And then we had also the substantial number of dropouts. So basically, the on and under vaccinated, we have 9.9 million as of 2023 versus 8.6 million in 2019, which is our baseline year. But noting also you see from the coverage bars, the coverage lines, the DPT1 coverage has restored back to 83%, which was what was there in 2019. And then the DPT3 is lagging slightly behind, still at 74% relative to 77. Note that while we are seeing the substantial numbers, African region is home to one of the largest population growth in the world. Next slide, please. So this gives the literal context of the numbers of zero dose. Basically, the blue bars represent the estimates of zero dose children using the WHO UNICEF estimates of national immunization coverage. And then so the dark blue bars are the zero dose, the light blue bar is the target. You could see by 2030 where the bar is supposed to be for the African region. Starting from 2019, of course, which is in the dark blue bar. You could see all the bars above, which are basically showing the backsliding and putting us off track. And you could see in 2023, we're still above the 2019 target. And the idea was we're supposed to have follow at least this trend line, maybe not very accurately, but then you could see we are clearly off trend in terms of this. And hopefully with the BCU, we'll be able to strengthen and restore back and be able to accelerate towards this target. Next slide, please. Next. So how does Ethiopia compare globally? Go back, sorry. So in the BCU in 2022, when it was drafted, basically looked at the top 20 countries with the highest burden of zero dose. Basically, the key parameter of selection was the numbers of zero dose. As at 2021, you could see Ethiopia was fourth on the list, basically behind India, Nigeria, and Indonesia. But then they've moved up the ladder by 2023 to the third position. Still, in 2021, we had 1.1 million zero-dose children in Ethiopia. And in 2023, we're having 917. So there's a decrease, and which is absolutely the trend we like to see countries having, but still the numbers are substantial. And we need to do more to be able to reduce the numbers. Some countries like Indonesia have really made substantial, you could see from the trend line, you could see how countries have moved either from their previous position, some going down while some went up a bit. So Ethiopia is one of those that slightly went up. DRC and Madagascar, you could see also moved up, and other countries similarly. Next slide, please. So in the Africa region, these are the top 10 countries, basically with the largest numbers of zero-dose children as at 2023. The picture is quite different from 2019, 2021 as well, so as at 2023. In 2023, there's 6.7 million zero-dose children in African region. This is relative to the global number, which is around 14.5 million. So you could see a substantial number, probably 40 to 50% of the global numbers of zero-dose are actually found in Afro region. The top 10 countries in Africa actually account for 82% of the total numbers of zero-dose children in Africa region. And Nigeria still remains on top. It was second, I think, in 2021, but because India moved down the ladder, so Nigeria took over with 2.1 million children. Then Ethiopia is second with 917,000 zero-dose children. You could see the top: Nigeria, Ethiopia, DRC, Angola, Madagascar, South Africa. So most of the countries in the top 10 are actually actively engaged in the big catch-up efforts to be able to reach zero-dose children and strengthen routine immunization. Next slide. I think this is my last slide. I probably be handing over to Ariel. Ariel, over to you, please. Thank you so much.
Great, and thank you so much, Ibrahim. Hello and greetings. My name is Ariel Higgins-Steele. I'm working with WHO headquarters, and I'm supporting the Big Catch-Up. In the next few slides, I'll give some background and reminders on approaches to monitoring, evaluation, and learning for the Big Catch-Up. This is important for everyone working on catch-up and immunization more generally, as we want to be generating evidence and lessons as the system expands beyond the usual focus of infants and children in the second year of life. Monitoring, evaluation, and learning for catch-up, it seeks to understand how to identify and reach older children who missed on-time vaccine doses. And by older children, we mean in this initiative going up to 5 years of age. And we'll be hearing about this from Ethiopia's direct and rich experience very soon. So you may be familiar, there's new guidance that was developed this year for monitoring catch-up, and it was developed by the Immunization Agenda IA 2030 Data Strengthening and Use Working Group. The guidance covers several key topics for catch-up. These are listed here. It includes delivery modalities, determining eligibility, recording and reporting doses for older children, monitoring and evaluation methods specifically, and catch-up indicators. The guidance is available on TechNet. The link is there on the right. It's available now in several languages: English, French, Arabic, and Portuguese. Next slide, please. The global guidance, it proposes a multi-pronged approach. You see here with the different colors and areas of monitoring and evaluation activities. So these pillars broadly are four. There's readiness monitoring, which is to ensure key preparations prior to implementation. Then there's adapting administrative health systems, which is very important to prepare data systems to record and report catch-up doses in an age-segregated manner as older children are vaccinated. Then there's targeted assessments and real-time monitoring, which are critical to assess the performance. And some of these methods include rapid convenience assessment or lot quality assurance sampling. Then on the right, there's case studies, and this is where we'll really be able to generate a deep understanding, look at all the data collected on how the systems are changing and emphasizing the routinization of catch-up and rather than a single initiative. Next slide, please. So this diagram illustrates the four pillars or the prongs of the monitoring guidance, and it goes across the course of the time-bound initiative of the Big Catch-Up. If we look on the left, the targets, service delivery, and monitoring methods, these have all been determined for the large part already by the country teams. And now most countries are in the phase of implementation. So that's this big center phase. For countries who are using an intensified approach, such as periodic intensification of routine immunization or PIRI, the service delivery modality, so this intensified activity, is accompanied by the collection of administrative data and there's supportive supervision occurring, and then followed immediately by some kind of a survey, rapid convenience monitoring to assess performance. And then ideally there's a review meeting looking at all the data from that round or that activity to inform and learn for future rounds. Then if we look at the bottom, of course, the routine immunization service delivery continues throughout to ensure that infants are receiving their on-time vaccinations and avoid accumulation of zero-dose and under-vaccinated children. Then if we move over to the right, the aim is that catch-up lessons are integrated into policy. Many policy revisions have already taken place, program and practice as a way to continually catch up any child who missed their on-time dose. Next slide. Now we'll turn to the Gavi Big Catch-Up Monitoring Forum, and many of you who are in country office are very familiar with this as the first reporting period just passed, but these are some reminders and there is one change. So this was developed in line with the new global catch-up monitoring guidance, and it's a reporting requirement for countries who are receiving Gavi support. So of the 35 countries receiving Gavi support. There are 4 sections, and again, these align to the catch-up monitoring pillars. So they're very much drawing from that. The first we can see here is readiness indicators, which look at the schedule, standard operating procedures, updated recording and reporting tools. The second section is on results. And so we have 2 parts of the results. This first part is on the status of implementation. So how is it being delivered? Is it through PIRIs? Is it through routine? And the status across each of those methods, modalities. Next slide, please. The results section continues, and here's where we have a change. So this is where the number of doses administered for Penta, so Penta 1 and 3, IPV, measles-containing vaccine, MCV1 dose 1 and 2, and BOPV are registered. This section has been modified since the first reporting period, and that was in Q3, so that just recently happened. There's 2 main changes that are appearing here now. So first, the under 1 age cohort does not need to be reported. It's incredibly important, though, to ease the reporting requirement. This has been dropped to prioritize looking at the older age groups. So you don't see that anymore as a requirement in the reporting form. Second, there's the disaggregation by ages by months 12 to 23 and then 24 to 59, which is preferred. So these middle columns. And if a country, there are a few countries who were unable to disaggregate in the first reporting period. So for some countries, and it's few of them that cannot disaggregate, there's an option to report doses to children in the 12 to 59 month category. So it's the second column from the right. Next slide, please. And the remaining sections of the monitoring reform form remain the same. So section 3 relates to assessments conducted, whether that's rapid convenience monitoring, behavior and social drivers, or any others. The summary findings and the changes based on the findings are reported briefly here. And then there's a 4th section on program learning and adaptation as countries are going through the course of their catch-up activities. Next slide. So this next slide just summarizes the reporting process through 2024 and 2025. The first reports were submitted by a majority of countries very recently, and it was very exciting to see all of the data. And with our colleague Erin Wallace at WHO headquarters, we'll be reporting that out in future sessions and with the UNICEF colleagues as well. So it's really exciting to see this. And Ethiopia was a really strong, had a really strong report, and we'll get to hear the deep dive soon. There are 6 reporting periods, so going into all quarters of next year. The upcoming reporting period is Q4, and that will be covering October, November, and December activities. And that report will be prepared as soon as it's possible in January or the beginning of 2025. In terms of responsibilities, WHO is the primary responsible for report submissions and working very closely with the Ministry of Health and with UNICEF and regional working group partners to facilitate. The data flow starts from the ministry and WHO country office and flows up to the regional office and the regional working group, and then to WHO headquarters, which is managing information at the global level on behalf of the Gavi Alliance. And then one last slide, please. Next slide. So finally, we wanted to really emphasize here the importance of case studies in the approach. And there's a guidance that's available online at TechNet now in English, and there will soon be one in French as well that'll be coming out very soon. The purpose and outcome is to have deep dives to understand and document lessons learned and the long-term impact on health systems. Again, to see how countries were able to quickly reduce the gap in immunity through catch-up activities, but importantly also how to institutionalize so catch-up becomes part of the routine system as one of our strategies to address zero dose and under-immunized children. The approach is mixed methods, which can be adapted from a standard protocol and sample tools. Again, these are available on TechNet and they'll be available in other languages. And countries interested in conducting a case study can reach out to the regional working group or to the WHO headquarters focal point, Aaron Wallace. So thank you so much, and looking forward now to hearing from Ethiopia on their catch-up experience. Back to you, Sarah. Thanks.
Great. Thank you so much, Ariel and Ibrahim. I think there are some questions in the Q&A section, and I can see Ibrahim has responded to a few of them. So people who have questions, please remember to post them on the Q&A button that's on the bottom panel. So now we bring on Johannes from Ethiopia, who will walk us through what Ethiopia has done over the past few months to implement the Big Catch-Up initiative in the country. And he also is supported by WHO and UNICEF, and as well as other country partners, as well as Gavi. So of course, at the end of the session, we'll also allow the partners to come in and maybe complement or add to whatever he will be presenting over the next 15 to 20 minutes. So over to you, Johannes.
Thank you very much, Sarah. My name is Johannes Lagau. I'm working at the Federal Ministry of Health as a Senior Immunization Program Advisor. I'm happy to be here to present the Ethiopian lessons and the progress on Big Catch-Up. On behalf of the API manager, Malcolm Wayaleo, he was not here today with another field mission. And again, I would like to thank Gavi, WHO, UNICEF, TechNet for arranging us this platform to share our experience to the global community, and we are happy also to share our experience to other countries and as well to learn. Next slide, please. So I do have a very brief presentation outline. We do have a background. I will show you the situation of zero dose in our case and the catch-up policy and the efforts that we have done in terms of reaching zero dose children, the lesson that we captured through this process, as well as the challenges and the way forwards. Next. Next slide. Yeah, as a country, as you know, Ethiopia is the second most populous country in Africa, which we have more than 112 million population, and most of our population were also living in a rural context, which accounts around 77%. And we have around 12 regional states, and we have 2 city administrations where we are implementing all these activities. Next slide. Next, please. Next slide. Can you hear me?
Yes.
Yes. Thank you very much. So just to show you some background information about the immunization program, in case if you don't know the Ethiopian context, we launched the EPI program in 1980 with 6 antigens. Right now, we have reached around 13 antigens were provided through routine immunization, including COVID-19 vaccine. And there are a few antigens like yellow fever, MAN-A, OCV, and NOPV was also provided as an outbreak response to protect our children in the community from vaccine preventable disease. Next slide. I just rushed because these are some background informations. Yeah, coming to the zero dose situation in Ethiopia, as you know it, and Ibrahim also presented earlier, we are the third, country in the list of, having a big number of zero dose children, which accounts more than 970,000 zero dose children were estimated in our country. We're living right now from with the estimate of WINEP and WHO and the UNICEF estimate. So next to India and Nigeria, we are the third country that we are having large number of zero dose. Next, please. Thank you. This is just to show you, the overall, immunization coverage since 2000. If you look at the Penta-1 coverage, the last 10 decades, the last from 2000 to 2010, we have been progressing on in terms of immunization coverage, especially the Penta coverage. But since 2019, 2020, 2021, 2022, there is a decline of immunization coverage, and we were having a large number of zero dose children, as you can see on the blue bars. Last year, the year 2023, we have progressed a little bit in terms of reaching zero dose children and addressing routine immunization, and where our coverage is for Penta-1 increased from 70% to 77%, we improved by 7%. Again, we also reduced zero dose children by 22% from the year 2022. So there is a little bit change from the year 2022 to 2023 by 7% of increment. We hope for the year 2024 we also reduce a significant amount of zero dose children. The next slide, please. Yeah, this is just to show you how we estimate zero dose children by a subnational level, by the regional level. As you know, the WINEC data is a national level estimate. It doesn't show us, the subnational estimate. We're very much challenged, to estimate our zero dose children by subnational or by the regional levels. Again, we looked at the data that we have, the DHIs to the admin data that we collect from the lower level, from health facility and district level. This data also shows us a high coverage of EPI when we looked at it. So both WINEC and the DHIS2 data that we have in our hand were not used to estimate zero dose children in our case. Rather, we used the DHS survey conducted in the year 2019 and the zero dose estimation conducted in a remote and under server setting were used to estimate our zero dose children in our case. Both surveys were used to estimate from the year 2019 to 2022. With these coverage surveys, we found that more than 3.9 million zero dose children were estimated in our case. As you can see in the picture, in the figure here, Oromia region were one of the biggest region in our case, which have the largest number of zero dose, accounts for more than 1.5 million. Amara is the second, which almost 655,000, and the next is Somali. So we try to estimate and indicate where our zero dose children are living in our local context. So this estimation was also done by a lower level, by district level as well, and it was shared to the subnational levels to use that estimate and find, identify, and reach those zero dose children. Next. This is just to show you the journey of the zero dose or the big catch-up effort. We actually started the catch-up vaccination since the year 2022. After we understood that we have large number of zero dose because of the conflict, the climate change, the COVID pandemic, the Ministry of Health has developed a catch-up guideline to address those children through the essential catch-up modality, where the vaccines were co-financed by government and was used from the routine one. But in the year 2023, there is a global initiative coming to support us, the Big Catch-up Moment. And at that time, we also developed an accelerated plan to reduce zero dose in the under-vaccinated children using the Big Catch-up Moment. Again, during the implementation of the intentional catch-up, we realized that at the lower level, there is a misunderstanding of zero dose. The monitoring system was not, uniform. Recording reporting system was not established. So, understanding this issue, we come up to develop a catch-up operational guide for our case. So, in the year 2022, before the launching of the big catch-up, we have developed, the BCU operational guide to facilitate the implementation of this BCU implementation. So the big catch-up was launched in June 2024. Since before the big catch-up launching, we tried to manage to vaccinate more than 335,000 zero-dose children using different opportunities of campaigns like measles, polio, COVID, HPV campaigns. And after the big catch-up implementation, since June to now October, we try to reach more than 300,000 zero-dose children were addressed using the big catch-up moment. And then in October, we realized that we need to deep dive and review this catch-up implementation, and we conducted interaction review for the big catch-up implementation. Then we try to document the best practice, the challenges, enabling and the limiting factors were identified and the action plans was also developed to proceed and move the big catch-up activity forward. Next slide. This is just to show you the guideline that we developed related to the big catch-up moments. So we have the policy guideline, the catch-up policy guideline. Then we developed the operational guide, and the third one is the accelerated plan to address zero-dose children, which is a big catch-up plan that was shared to the global community for resource mobilization as well. We also indicated that in the big catch-up document that we have already estimated our zero dose close to 4 million zero dose were also found in our case. So within this catch-up moment till 2025, we plan to address at least 85% of those backlogs of zero dose children. So our aim and our target is to address at least 85% of those backlog of zero dose children. Next slide. Just to show you the intentional catch-up and the big catch-up difference, just the intentional catch-up was initiated before the big catch-up moment in the year 2022, cognizant to understanding of, having big number of zero dose in the many areas were not, accessed for routine immunization because of the conflict. So during that time, Penta, Rota, PCV were given age less than 24 months. For polio and the measles, it was around up to 59 months. And the vaccine was from the routine stock and was co-financed by government. But for big catch-up, we tried to waiver our policy and we pushed Penta, PCV, IPV, and the measles up to 59 months of age. Except the Rota will be provided until 24 months. Recently, we also received, oral polio vaccines from JPI as part of, catch-up vaccination. And it will be also provided up to 5 years of age for children with other vaccines as well. Next. I just want to show you the strategies that we followed to identify and reach those zero-dose children. There are different strategies we have designed to identify and reach zero-dose and under-vaccinated children. So the first one is, head count, then followed by vaccination. So there was, house-to-house enumeration of, zero-dose children was conducted by volunteers and health extension workers. Then once we get the data, those children were linked to static service like outreach and PD programs. We actually conducted the head count or the enumeration by using different digital tools like ODK and the survey CTO. to map those zero dose children as well. And the other strategies that we used, because of the context that we have in the country, we tried to design as well another strategy that was, simultaneous head count and vaccination, where volunteers and health extension workers did house-to-house enumeration, and then immediately when they get, zero dose and under vaccinated children, they immediately, refer to the vaccination post, which was organized in and out of health facilities, very close to those, volunteers who are working in enumerations. The third strategy was integration with other campaigns. So there was, different campaigns was conducted like polio, measles reactive vaccination, HPV, COVID, nutrition service were, implemented in our case, and we try to integrate the zero dose identification and the vaccination with these campaigns as well. The last strategy that we used was, service integration at the health facility level. Whenever children are coming for well baby clinic as well as sick child visits, we will ask them whether they are, vaccinated or not, and if they are not, vaccinated, they will be linked to the immunization service in the health facility. So these are, the strategies that we used to address or identify and vaccinate zero dose children. Next slide. For certain or for specific areas, like we have conflict affected areas in our case, and we deployed very specific strategies for those areas, like a hit and run approach were also used to identify and reach those zero dose children whenever, the health workers get an access to reach the community during that conflict period. They can, hit and run and vaccinate those children. And the staggered implementation of the identification and vaccination of, zero dose was also conducted. They didn't, go with the national schedule. They see the context at the local level, and then they implement accordingly. So there is an implementation was, in a phased manner. Again, humanitarian partners like UNICEF, WHO, IRC, and other developmental partners were also engaged in these conflict-affected areas to support us in addressing, identifying, and vaccinating zero-dose children. In addition to that, they were also engaged in distributing of logistics and the vaccines to the lower level as well. Military escort was also used in this case, especially to deliver supplies to the lower level. Again, there are areas which are not also accessible because of active conflict in those areas, and we are looking, appropriate time to address them as well. Next slide. As part of preparatory, we actually try to advocate, the zero dose agenda at the ministerial level, and now it becomes a ministerial flagship initiative. So whenever, an issue of zero dose, the minister has, open her doors for us to facilitate everything to be implemented. So now it becomes a flagship agenda after, conducting several advocacy to the ministers and to different stakeholders. And again, we also leveraged different resources from existing budgets, like from Gavi, HSS, EF, and new vaccine introduction. We have leveraged the resource from CDC, TFGH. We also leveraged the resource from UNICEF, Gavi, SIF program, IRCZ, WHO, TCHI, Save the Children, GSI, PAS, Core Group, Early Faith, and others, were contributed their resources to address, these zero-dose children as well. Technical assistants were also leveraged wherever, they are assigned, whether they are, routine, whether they are assigned in a COVID or in another program, they were, mobilized to support, the big catch-up efforts as well. Next slide. Yeah, this is just to show you the advocacy workshop that we conducted at the higher level. There was, the advocacy meeting was conducted by our ministers for the parliamentarian regional presidents, and the stakeholders to get, a buy-in and monitor, the implementation of this the big catch-up efforts in our case. And several regional health bureaus also cascaded this advocacy workshop in their context as well. And we also launched the big catch-up moment in June. So in the presence of many medias to advocate, for the community to be engaged in this task. Next slide. Next slide. Yeah. Again, we also conducted lower level social mobilization activities to, create an awareness for the community about the second opportunity of getting the vaccine for those children who miss their routine doses. So several TV and radio messages were, disseminated. Community level dialogue was also conducted in some areas as well. Panel discussion at the media and at different level also conducted. Next slide. Yeah, this is just to show you how we monitor and evaluate our catch-up activities. So there was a daily virtual meeting was conducted with a subnational team, including partners who were also engaged in this platform. This was actually during the first 10 days of the big catch-up moment. We actually started the big catch-up in a form of campaign. So there was intensive and a daily virtual meeting was conducted. Google Sheet reporting mechanism was also deployed to collect data from the lower level and to take action according to the report that we get. Rapid community survey was also deployed right now to assess, whether we are addressing those children in the community level or not. Supportive supervision for health workers for program peoples was also conducted. And we also conducted an interaction review to see what are the best practice, what are the challenge, what are the enabling and limiting factors related to the big catch-up implementation. Then using those information, we actually developed an action plan to move the big catch-up activity forward. And again, lastly, now we have started documentation of lessons that we have. There are partners from CDC, they are volunteers to support us, and there are works started to document the lessons of big catch-up effort in our case. Next slide. In terms of monitoring and recording tools for big catch-up and the catch-up, we have a record, we have vaccination card, and we have the reporting modalities. So in terms of recording, registers were used. We didn't deploy different registration form for 0 dose and under vaccinated. We just use the existing registration of routine immunization, but we make it a separate way. So the back side of the register will be used for 0 dose. The front side will be used for routine core in order to differentiate both reportings. Vaccination card is the same. We didn't develop another vaccination card. Reporting for modality for routine, especially for 0 to 11 months, we used the BHIS to the routine system, but for 0 dose, which are 12 to 59 months, we used Google Sheet format to collect the reports. We also indicated our monitoring indicators, so PENTA1, MCV, and identification of 0 dose by age, by antigen were also indicated in our case. So we set our monitoring indicators accordingly. We also developed supportive supervision focused on catch-up, and it was also digitalized by ODK. So whenever there is a supervision at the lower level, it was conducted by ODK format, and reports also synced to the national level, and we analyzed and provide feedbacks accordingly. Virtual meetings regularly every other day, and weekly was also conducted right now. Rapid community survey was also deployed. I just actually have a slide on this regard, and I will show you that one. Interaction review also one of the monitoring tool as well. Next slide. So this is just to show you our reporting formats. So this is the head count registration format in the right side, and we have a tally sheet format for the catch-up and the 0 dose. It was disaggregated by age, 12 to 23 months and 24 to 59 months. And we have a reporting template at the bottom. So reporting will be conducted by antigen type and by age as well. Next slide. Coming to the overall performance of zero dose vaccination, as I told you, we started the catch-up vaccination before the big catch-up moment using existing platform like campaigns. So if you looked at the third column, we vaccinated more than 334,000 zero-dose children using the opportunity of different SIs, more than 5 SIs and routine catch-ups. And again, with the big catch-up moment, we vaccinated more than 304,000 zero-dose children. This is just one round of catch-up. So you can compare that the yield of one round of catch-up with other 5-time SI integrations. So there is a big difference between the big catch-up and the previous one. In total, we vaccinated more than 638,000, and we try to reduce by 60% right now from the backlogs. Next slide. This is to show you antigens that was provided during the big catch-up moment. If you look at MECV and Penta, we vaccinated more MECVs than the Penta one. We actually monitor zero dose by Penta, but if you look at the MECV and the IPV, most of the children were actually missed Penta measles compared to Penta. Then the reality on the ground as well, we found more children were not get measles compared to the Penta as well. So just to show you, MCV1, we try to vaccinate more than 375,000, and Penta is around 300,000. So it's a huge, more than 75,000 difference between these Penta and MCV vaccination as well. So we evaluated, catch up in terms of, especially by measles, the yield is more than, Penta one as well. Next. Yeah, this is to show you how we are doing, the rapid community survey, the RCS. So we have deployed, the rapid community survey tool to the lower level using ODK formats, and our supervisors on the lower level have been trying to do, rapid community survey, so house-to-house visits. So far, we try to visit more than 26,000 households, and we identified, more than 90,000 and 5 children in those households, and they identified around 525 zero-dose children during these RCS visits. So those, zero dose was linked to the community, but what this RCS told us, still, even though we conducted big catch-up in those areas, there are still children who are not, getting the vaccine. So we need to make sure that, every children in local level should be addressed and vaccinated. So RCS will be one of our tools to validate, our big catch-up effort going on the lower ground. Since we don't have, surveys, we don't conduct surveys regularly. So RCS will be, an intermediate solution to validate our coverage of big catch-up. Next slide. Yeah, this is just to show you that the big catch-up effort has also contributed to not only for children who missed their vaccination, but also it contributes to strengthening the RI, especially those children from 0 to 11 months who delayed their vaccination have got a chance to get the vaccine as well. And I do share you one case scenario of Amara region as well. And it also contributed to the primary health care service. And so the legacy of, big catch-up, or the benefits of big catch-up effort, it's beyond, the RI as well. And it goes to as well to the primary health care as well to strengthen that one. So this is, some of the things that we jot down that the contribution of BCU for other service to be strengthened. Next slide. Yeah, this is the slide that I wanted to show you. When we conduct, the BCU campaign in one of our regions, this is a case scenario, and as I presented it as an example. In Amara region, we vaccinate many, under one children who missed their, routine immunization because of different reasons in the region. So what BCACHAP gives us, an opportunity to address, those delayed doses of, children who are under one. So if you look at the Penta one, they try to address more than 43,000 during that BCACHAP moment. Almost equivalent to those are zero dose. We say zero dose actually from 12 to 59 months who didn't get the Penta vaccination. But those who are under one, we said them delayed doses for routine immunization. So they vaccinated more, in total, they vaccinated more than 3,000 um, children 0 to 59 months for Penta 1. So it contributes a lot to address, those delayed doses. So all regions in our case conducted routine immunization vaccination along with the BCACHAP vaccination program. Next slide. This is also to show you, the integration effort when we conduct the BCACHAP. We also integrated like malaria, nutritional screening, deworming, vitamin A, pregnant and lactating women screening, public organ prolapse identification, fistula identification, UVP, cleft foot and cleft palate children were also identified. So the contribution of BCACHAP also, maximized to other services as well, and it really benefits, the program as well. So we are aiming to provide, one-stop shopping service for the child. So if you look at the screening of malnutrition, it is close to 4.1 million children were, screened. So it tells us, in another way, we reached out, more than 4.1 million to be also looked at, at the community level for vaccination service. And most of them get actual vaccination, but nutritional screening was also conducted for them. Next slide. Coming to the challenges that we faced during the implementation of this BCACHAP in terms of leadership, management, and coordination, we have seen that during our supervision, there are suboptimal functionality of, coordination platform at the lower level, especially below district level and facility levels. There is a competing priorities in our case, like the conflict, the malaria outbreaks. So all this, competing with our BCACHAP effort, and it's really one of our challenges to coordinate efficiently the BCACHAP moment. In terms of financing, as you all know, the BCACHAP has only the vaccination support only from Gavi. We really thank Gavi actually for the vaccine full support, but it doesn't have, operational budget to identify and vaccinate zero dose children, even to monitor the implementation of this BCACHAP. What we did was, we leveraged the existing resource to cover, the financings. So there is a huge financial gaps to really reach all the zero dose children and under vaccinated children in the pocket areas. We also had looked at as a challenge. There was also health workers' perception. They said that there is no zero dose in their catchment areas. So there is a blunt, perceptions we saw at the lower level, which will need to be addressed through trainings and awareness creation. There is also a challenge by conflict-affected areas to identify and reach those zero dose children because of the access issue and the humanitarian partner that we have were also limited, and they didn't cover all the areas because of the scale of the conflict in our case. In terms of demand generation, there was a limited community mobilization at the lower level, especially in an accessible area where we don't have radio and television access. We need to have volunteers to engage in this part, but there is no operational budget to engage those the community mobilizers to be a part of this work. We have seen also a challenge in monitoring, recording, and reporting. So starting from the availability of tools and the consistency and the completeness of reports, in terms of having robust reporting mechanisms, especially we are using the Google Sheet format. It is very susceptible to some changes in the format, and quite challenging to collect data using that one. So these are also the challenge that we identified during our interaction review. Supply shortage for Penta also observed. Next slide. As a key lesson, during this implementation period, we collect few experiences or lessons that need to be shared to others as well. So making zero dose as a flagship agenda really facilitates the implementation of the big catch-up effort. So whenever we think a new initiative to be cascaded to lower level, we need to make it as a flagship agenda by the higher levels of the ministers. And leveraging existing resources and opportunities also very important, because we are living in a resource limited country. So whenever there is an opportunity, we need to leverage. So the experience that we get by leveraging other resources, we try to vaccinate all those children that I mentioned. So this is also one of the lessons, and I will continue to do this one. Contextual and the community-centered strategy is also very important, especially in our case. We have climate change, we have a pastoral context, we have agrarian agritourism, we have a conflict. So devising, different context-specific strategies is also very important to, move forward in such a big initiative. Zero dose identification and reaching, and then also labor intensive as well as resource intensive work. It is not a simple work like we think of, like campaigns like measles and polio. These are children who are, not accessible, and finding from, thousands of children, a few not vaccinated is very challenging and resource intensive work. And we have to consider whenever we are trying to implement such initiatives, there will be dedicated resource to be for this work. Deployment of digital tools were also very important for our case. It facilitates identification and vaccination of zero dose children. So the tools that we used for head count, like ODK and the survey CTO, were really important to facilitate identification. Next slide.
Maybe you'll move a little bit faster so that we have time for question and answer.
Yeah, I just on the way to finish. Yeah.
Excellent.
As a way forward, now we are planning to make the catch-up a routine program. It should be also done regularly through static outreach peer programs. Whenever we have a resource, we are planning to have a campaign modes to reach more the zero dose children at one time. So this is our way forward. But there are also things that we are going to improve, like the reporting mechanisms, availability of tools, monitoring mechanisms will be also implemented according to the gaps that we have identified during our interaction review. Next slide. Last slide. Now we are, implementing the big catch-up. As I told you, we have received, millions of doses of vaccines from Gavi. We really thank the generous support of Gavi, but operational budgets, we do have a gaps on that to fully implement, the big catch-up efforts. So now the ministry has identified, or estimated the budget that we need to vaccinate the remaining zero-dose children. Close to 22,000, 22 million USD were estimated as a budget that is needed for implementing the zero dose and under vaccinated children. This needs to be also mobilized from the government, donors, and the partners to address those remaining backlogs of zero dose children. So we really call partners and the donors in this meeting to support us, the effort of the government on this regard, and we do have a huge amount of budget caps on this part, and we hope that partners and the donors will come and support on this regard. So this is the budget caps that can I show you for all of you. Next. This is action photo where we captured in the field visit during the big catch-up moment, and I do acknowledge those health workers who are working in a very challenging environment on the lower ground. Next slide. This is also the same, just to to think of how the health workers are really working in a challenging environment, and we do recognize them as always in such a meeting. And lastly, I would like to thank Gavi, Sarah, as well as WHO team, UNICEF, TechNet, for giving us this opportunity to present to the global community in this platform. And if there are any questions and comment reflections, we are happy to respond for that. And thank you. Over.
All right, thank you so much. Thank you very much, Johannes. I think you've done an excellent job of really laying out the situation in Ethiopia and all the efforts that have been put in place to implement the big catch-up. I do see a lot of congratulatory messages on the chat. I also see several questions that have come up. I also see a hand raised by Flint, but I wonder, Flint, if you want to come in, or we first allow UNICEF, WHO, Gavi. We have Emanuela also on the line, who is the senior country manager. If you'd like to maybe...
Sorry, it was an accidental hand, but I just want to thank the team for the great presentation. Thank you.
All right, great, thank you. So country office colleagues, we have UNICEF, WHO, Gavi, we have other partners. Johannes, is there anyone there who might want to maybe complement what you've presented? I've seen a lot of questions, Almaz and Daniel, on demand generation and awareness of healthcare providers on the initiative, the Big Catch-up initiative. I don't know if you would like to comment on that.
I come in?
Sure.
Thank you. Thank you so much, Johannes, representing the country team. Regarding the awareness among the frontline health workers on the existence or presence of zero dose in their catchment areas, I responded through typing, but just to explain some of them. They have been engaged. Health extension workers are the frontline health workers providing immunization services in Ethiopia. And because of the admin coverage that masks the existence of zero doses, we have been used, the health extension workers, to be engaged from very beginning. First, during the capacity building, what does the definition of zero dose and under vaccinated? How the possible reasons for them to miss the routine immunization. After that, we engaged the health extension workers to be part of the primary health care unit team and the Kabale administration, the lower structure, and social workers to go and make a house-to-house enumeration to make sure that there are, I mean, there is no zero dose. Then they found that there are zero doses in some of the health facilities, and mothers and or parents or caretakers were asked why this child is missing this vaccination, and they were received the reason the mothers not like the reason why their children are missed. So having this as an input from the caretakers, from the community, the health extension workers were aware that children are really missing their routine vaccination. So engagement, by engaging them, I think they have, I mean, in some areas, they are now realize how they were missed, why they are missed, and where are they living, and how can we reach them. So we engage in discussions. So in this way, by doing, their awareness has been increased, and we witness that in field monitoring. That's number one. Number two, to monitor the quality of planning, implemented the national team, partners, all of them were on the ground to support the regions, from regional health bureau, from WAREDA, from primary health care units. The team were deployed to the ground, to community level. So that's what does it mean? Engagement of all, program managers, service providers were also engaged in all process of BCU under the leadership of the local governments, the high officials in Ministry of Health, and at different subnational levels. So by this commitment, I think this is the reason how we have used engaging all the stakeholders in this process. Thank you.
Excellent. Thank you very much, Almaz. I don't know if anyone else on the UNICEF side, Daniel, Gemera, I know you're online. We also have our WHO colleagues. Daniel, did you have any reflections from the UNICEF side? And then we go to WHO. And of course, I do see some hands are raised also from the participants. Any reflections, WHO, UNICEF, Gavi?
Can I come in, Sarah?
Sure, yes.
This Makurna
You
from
can turn on your
WHO.
camera so we can see who's, make it more interesting.
Yes, am I loud enough?
Yes.
Yeah.
Yes.
So I appreciate Johannes. He presented it very well, and of course, that was just the country was involved in the BCU for the last starting from 2022. Actually, the BCU, the CON, comes in 2023, but reducing the zero dose was just started in 2022. So I think because of the pandemic and the other conflict as well as the climatic reasons, the country has high burden of zero doses, depending on the WANIC or any estimate available. So partners were also engaged in supporting the government. And WHO also conducting, having its own, support to reduce the zero dose by, deploying its full staff on the ground to assist in the to conduct the campaign. So technically, we're part of to develop the guideline initially, and then during the implementations as well. So this is just I want to emphasize that this is a concerted effort that reduces the zero dose by 16% in a year is quite significant achievement with regard to the burden we have. Of course, after the BCU, we may not continue in campaign mode, but the linking to the health facilities, integrating with the other campaign initiatives For example, we'll have measles SI, we'll have also yellow fever preventive mass campaign or any outbreaks campaign. These initiatives reaching, the 0 dose will continue apart from the PIRI, the AVW, and other initiatives. So this is, I'm trying to say that, we'll never stop with this, one-time activity, but the Ministry of Health as well as the partners are fully engaged, to continue the zero-dose fighting in a different platforms and avenues. Thank you.
Excellent. Thank you, Mekonnen. And I think that addresses some of the questions that have come up in the chat about after big catch-up, how is the country looking at institutionalizing or routinizing catch-up efforts? Maybe let's hear from Emanuela, the Senior Country Manager for Ethiopia from Gavi.
Well, thank you, Sarah. And firstly, thank you to Johannes for the fantastic presentation. And thank you for all the team who has been behind that work. Mine is just to complement in two areas, building from the IRMA framework on advocacy and then on budgeting. On advocacy, I think there's a lot to learn from how Ethiopia worked to really get the political and leadership advocacy and cascade that down all the way to the lower levels. I think there were some questions on how will we present, how did they address issues of hesitancy, multiple vaccinations for a child in one session, etc. But I think it's also to reflect back on the top-down messaging that has come really not just from ministers level, but also with regional president engagement to really drive home the message of why is it that we're pivoting and focusing more on zero-dose children, and what does this mean when we address this, and looking at how zero-dose is now within Ethiopia, within the Ministry of Health, seen as a proxy indicator for the health of the system. I think it's that level of advocacy and not just one-off. I think you will have seen from Johannes's presentations, you had pictures of the former Minister Leah, you've had Dr. Dereje, you have Minister Mektes, who have all been driving home this message at various avenues. I think Mekonnen has spoken to how you address the zero dose with the different initiatives. It's not just during the BCU campaign that you have this political level advocacy. It's how do you use your measles campaign to also be talking about reaching zero dose children. And I think the second point is really on the budget. As most people on the call know, the big catch-up initiative did not come with operational costs. So I think there has to be a lot that can be learned from Ethiopia on reflecting on the available funding levers, especially speaking from a Gavi standpoint. How is it that you look at your COVID delivery support and say, with the shifts that we're seeing with COVID, with your existing funding, what can you pivot to really address zero-dose children? For Ethiopia, at the time when the big catch-up campaign initiative was moving, the country had just been approved for their FPP. So how are you using your health system strengthening grants, your equity accelerator grants to really address on the zero-dose initiative and really focus on those areas? So just to compliment Johannes and to really thank the team for the great presentation. Over.
Great. Thank you very much, Emmanuel. I think you're pressing on something that is a task and a challenge for most of our countries. We have seen from the budget that big catch-up is a bit resource intensive and it requires intentional investments. And I think we have to start thinking about it. A lot of the countries that have reported in their quarterly report are indicating the funding gap for the upcoming planned activities. And so as an alliance and as partners with our countries, we have to think about how we prioritize this support so we can see this journey to the end of 2025, as Johannes has indicated. So I do see some hands that are up. I don't know if there's any additional reflections, or I can start to take these questions in the chat. And I think some of them are directed at Johannes. So Johannes, maybe you can look at some of the questions already there. I see Ibrahim, your hand is raised, and then I'll come now to Tawadros and Haptamu, who have their hands raised.
Yes, thank you, Sarah, and thank you, Johannes and Ethiopia team. Fantastic presentation. I think it shows the level of work and commitment that went into this. But also what I love about what they did is actually saying, look, we've done this, and then we need these resources to move forward. So I think that is fantastic. It gives a very good opportunity to negotiate. Just quickly, I think they highlighted the need for tailoring different strategies across different sectors. There were questions coming in from there. You could see how they tailored their strategies to address conflict and different settings as well. But also looking at the granularity of the data they presented, it gives an opportunity to actually interrogate some of the strategies that countries have proposed. For instance, saying either integrating with SIA or doing series or catch-up. So I think there's a lot that could be learned from there. Just to clarify, two quick items, Johannes and Ethiopia team. For the rapid community survey that you were doing, I see the data you presenting, the number of zero doses that haven't been reached. Well, it would be interesting to hear from you if you actually looked at those that were reached using either your essential catch-up or your big catch-up, because I think that could supplement the BCU data that we're using, also validate some of what we presented. Then with respect to the zero dose numbers, I think it was in Oromia that you presented. I see heavily it was looking at more of the routine zero dose, basically those under one. Just to understand how you segregated that from those that are overdue, basically the zero dose targets for the big catch-up. Fantastic presentation. Thank you. And I think we look forward to working more with you to reach remaining children. Thank you, Sarah. Over.
Great. Thank you very much, Ibrahim. And I think you pointed on something that's very important. There is a rapid community survey that Ethiopia has conducted. I think across all of our previous webinars, we have not seen this approach being used. So I think later on, we might come closer to looking at how this has been rolled out versus the data coming out of it versus the admin numbers that were there. So absolutely agree with that point. So we come now to our participants. I do see some hands up. Sorry, I have to scroll all the way up. We have close to 200 participants. Okay, Tewodros, over to you.
Thank you, Sarah. Thank you, Johannes, for the good presentation reflecting the Ethiopia's experience. I am Theodros, working with JSI, based in Ethiopia, and we closely work with the ministry. And the presentations that Johannes made, it reflects what we have been through, and it is what was on the ground. Just I want to reflect on the national level, the advocacy component particularly, that was very exemplary. Currently, big catch-up is considered as one of the top issues, the top priority, a flagship agenda for the minister herself. So it has been taken from immunization team, beyond immunization team, beyond MSH team, up to the minister level, and it is considered as one of the key components. That happened because of high-level advocacy, including the minister, the state minister, members of parliament, at national and sub-national level. That is something that we can take from Ethiopia, how we engage political leadership for routine immunization beyond big catch-up. That is something that we, as Ethiopia, that was done properly. Another point, particularly looking in terms of policy, I think Ethiopia, it was ahead of, in terms of development of policy, like catch-up policy for reaching children beyond the age of 2 years, how to vaccinate them and how to reach them. That was developed even before big catch-up. But when big catch-up was a momentum, that was used as a springboard, and further operational guide for big catch-up was developed. Then during that big catch-up, some practical issues were defined that make the big catch-up easier. For example, big catch-up on the generic, it is children that didn't receive the Penta 1. That is the definition. But when we make that one operationalized, it was clearly defined. If the child is under the age of 12 months, that child was defined as delayed dose, not zero dose. But if the child has already passed beyond 12 months, that child was defined as zero dose. And even during the recording, it was segregated. If it is under 12, just it is part of the current cohort, and it is recorded into the DHIS2. But when the child is beyond the age of 12 months, that was recorded as part of the big catch-up or reaching the zero dose. So there were some practical issues that were considered during operationalizing the big catch-up, which was also another important lesson from Ethiopia. Looking forward, still, as you saw, it's about 16% of the children that are reached. So as a country, we have already identified which districts are the priority districts. There are around 447 districts which are prioritized for having high number of zero dose, and they are targeted for looking forward for the next year. These are going to be the area. So looking, these ones are targeted
I think we want
and
to keep it short. We only have 9 minutes and I see additional hands. So just wrap it up maybe.
thank you. Yeah, so these are the areas that Ethiopia is bringing up, and looking forward, the 447 waradas will be the area of focus for reaching zero dose. Thank you.
Thank you very much. Okay, Haptamu, and then we'll go to Aschalu. We keep it very brief, huh? Over to you, Haptamu.
Sarah, for giving this opportunity. I just want to, my name is Aptamu from Chai Vaccine Program. First of all, I would like to congratulate Johannes for his excellent and informative presentation. I just want to give few compliment about Ethiopia. Ethiopia has started seeing addressing zero dose problem in different perspective. One is seeing the problem in terms of HCD approach, human-centered design approach, driver identification, root cause analysis, and co-creation of intervention with full engagement of community. That helps for sustainably addressing zero dose children. So we have started that work in Ethiopia, which is important for the sustainability. The another thing is relating zero dose with last mile delivery. If there is a last mile delivery to health fast rehabilitation will be conducted uninterrupted, stock out will be decreased, zero dose number will be reduced. Is another perspective that Ethiopia is utilizing now. The third is PHSO approach, strengthening the linkage between health center and health post in terms of planning, review meeting, mentoring, support supervision, and so on. So this is another perspective that Ethiopia is doing. I think that will contribute a lot for Ethiopia's work in the future. Thank you. Over to you, Sarah.
Thank you very much, Aptamu. And then Aschalu, then I see a hand raised from WHO country office. Aschalu?
Hello, can you hear me, Sarah?
Yes, we hear you.
Can you hear me now? Okay, thank you. Thank you so much, Sarah. Yeah, I would like to add my voice in congratulating the Ethiopian team for great work. This is a fruit of a strong partnership, I can say. So my point is more on the integrated service delivery. I think you are thinking in the context of identifying a missed community beyond a missed child. And since these missed communities are deprived for they have multiple deprivation. So it's good that you showed us the children and women reached during this BCU. If you can speak more about how this integration is planned, jointly monitored and implemented, that would be much appreciated. Otherwise, thank you so much for the great effort. Thank you.
Great, thank you very much, Aschalu. So we will go back to the country team. Johannes, I think after Ezekiel, I will allow you to give, and Daniel, allow Johannes to give us a final reflection. Particularly, I think one question that's coming up a lot is what happens after this? There's a funding gap. There's a progress that has been made with the 1P conducted since July to October, with reaching about 300,000 children. So is this sustainable to say that we'll reach the 85% target by the end of 2025? So I want you to make a small comment on that. And again, maybe you can wrap it up for us in terms of how you see catch-up efforts going after the big catch-up initiative ending in 2025. So, but first, let's go to Ezekiel and then Daniel. Very briefly, because we have 5 minutes, and then you have to allow Johannes to wrap it up for us.
Ezekiel, it's me now.
Okay, very
I'm using his computer, yeah.
okay.
Actually, I just wanted to respond, to that 3.3 million, the remaining 3.3 million business. Mathematically, it may not be possible, of course. Arithmetically, we cannot finish that one in a year. But
Yeah.
let's consider that we're calculating the zero dose from 2019, not from 2021. And the progress we made in 2023, meaning, increasing by 7%, and decreasing zero dose by, from 61 to 70% DPT1 coverage, more than 9%. I think that gives hope that we may really, decrease significantly the zero dose. Arithmetically, it may not be possible, but we can still reduce a major amount of, significant number of zero doses. And, the linking to the primary health care, routinization, the campaigns, that are coming forward, all are, giving us a forum to reach more children of zero dose in the coming years, 2024 and 25. Over. Thank you.
Great, thank you, Mekonnen. I think you do summarize it very well. I think it speaks to the need to really routinize these catch-up efforts, acknowledging the efforts that had been put in place before the big catch-up was launched in 2023. Thank you very much. Daniel?
Yeah, can you hear me? Hello?
Yeah. Yes, we
Oh,
hear you.
I don't know. My camera is not working. Oh, thanks a lot. I think also for me, I would like to add, I think when you look at the numbers in terms of the reaching 3.3 and that it will take 3 years, but I think the country has done quite tremendous because it's quite commendable that with even the quantities of vaccine they have used, it was mainly from the routine stock. And I think with the supply situation improving, we hope that it will be possible actually to reach quite a significant number of children in 2025. I think the only challenge would be because we will still need a bit of catch up, though we are routinizing, but we need to still have at least some few rounds of catch up to be able to reach more children, and then we go into the routinization of these efforts. That's what for me I would see as important. I think as we're also moving forward, because we don't know whether we need to have another time to also Ethiopia to present. We need to go also back to the other strategies when we look at more longer term strategies on the restoration and the sustain. I think those are the principles of reaching zero dose. And I think for me, I would really emphasize on estimations at service delivery point, knowing where the actual number of zero children are based. Today, when you go to most of the facilities, I think from Johannes' presentation, you will see that admin coverage, it gives us high numbers. But in the actual sense, it requires the different other efforts to be able to identify where are those actual zero dose. And I think that's where we need to employ different innovations to be able to sustainably reach those children, especially at service delivery point. That's what the few points I wanted to add from my side. Thank you.
Okay, great. Thank you very much. And I think your response and your contributions lead up to one of the questions that's on here about continuing to identify these children and identifying which children were identified as zero dose and vaccinated as zero dose. And then once we establish that contact, how do we continue from there? So I think the different approaches that Ethiopia has taken to implement catch-up and big catch-up activities is very well appreciated, and extensive efforts, particularly the slide on the conflict-affected areas and the different approaches that Ethiopia has taken to really be opportunistic, to leverage different strategies to reach these difficult communities. So maybe Johan, to give your final reflections.
Yeah, I really thank you, colleagues from the country team who supported me in responding, some of the questions. I just only focus on the sustainability issues, which actually really very important. We have a motto actually at the ministry. We don't have to create a new zero doses from the new cohorts. So our main focus area is, doing and strengthening, the routine immunization activities right now. in order to address, those, routine targets. The second agenda that we have is, addressing the backlogs through catch-up, PIRI, by integration, by many other opportunities. So far we have reached, this level of achievement. But in the future, we are focusing to institutionalize, the agenda of catch-up vaccination in our routine immunization program. So we have devised a strategy. We want to continue catch-up through routine system. Whenever we get a child who is not vaccinated, if it is under 5, we will get the vaccine according to our schedules. Plus, whenever we have outreach, we will continue to integrate the catch-up vaccination. Whenever we have a PIRI, for routine immunization, we will integrate, catch-up. Whenever we have other SIS like polio, measles, whatever. For example, that we have an upcoming measles SI coming. We have a polio campaign next week. We are still integrating the zero-dose agenda to be a part of it. But with this pace, we cannot, clear all the backlogs. So that's why we are requesting such amount of, resources from our donors, partners, and the government to really address those backlogs of zero-dose children within a short period of time. If you get, the resource, especially the financing part, we have the vaccine now. We can organize series, small campaigns in different areas and address those, missed community within a short period of time. But still, we don't quit, to do our catch-up vaccination, even though we didn't get any budget. We will still leverage any existing resource within the immunization, outside of immunization. So we'll continue to do that one, and I hope we will try to address, those missed children through catch-up and other opportunities. I think this is some of the things I wanted to reflect, but one issue that Ibrahim mentioned about the definition of zero dose. We actually very challenged with the definition of zero dose. For the routine cohort, for example, from 0 to 11 months, even though we know them delayed their schedule, we said that we didn't categorize them as a zero dose. Zero dose will be categorized in our case from months 12 to 59 months. If a child is found to be not vaccinated for routine immunization, age above 1 year, we said it is zero dose. But if it is below 1 year, we know that it's not vaccinated, but we, for the sake of, implementation, feasibility, we said them delayed doses, and they get the vaccine, and it will be also reported through the routine immunization program. So this is my reflection, but in general, the comments, the feedback that you have provided us here, we really consider it in our plan. Especially there are many questions that raised here in this chat. We wanted to capture them and wanted to even look at it again, and if it is really helping us, we can even include it in our action plan and improve our catch-up vaccination in our case. So thank you very much, Sarah, for moderating us and giving us this opportunity at this level. And I hope we will come another time to present with another success and the lessons for this community. And as the Ministry of Health, on behalf of the Ministry of Health, the API community in the country, we really appreciate the effort, the support that we get from our donors, partners, and even the technical support that we received from the global regional level. We really appreciate all those efforts to address those, our challenges in our country. And thank you very much. Have a good time as well.
Great. Thank you very much, Johannes. Thank you so much to the team Ethiopia. Well done to everybody. And thanks so much for our participants and your great questions. We know we have many of them that are yet to be answered. Feel free to reach out to any of us and we are happy to address them after this call. We unfortunately have to end the call because we have other people having to move on to other activities, but really just heartfelt congratulations to Team Ethiopia. Despite the difficulties, you've done a fantastic job over the last 1 year. So keep it up and looking forward to learning more about your progress in the next year. Have a great afternoon, everybody. Thank you.
Thank you. Have a good
Thank
time.
you.
Thank you.
Thank you.
Bye-bye.
Bye.
Thank you.
Bye. So what's yeah.